Now I'd invite Dr. Chandrima Paul for her talk on raised intraocular pressure, because as much as we fear hypotony, raised intraocular pressure and an unachieved target IOP is equally hazardous and fearful.
How do you go back? Yeah. Okay. So good morning, everybody, and thank you, Dr. Purvi, for having me in your course. It's indeed a pleasure to be here, and I take you through high intraocular pressure with high and low blebs, and what are the strategies that I follow. But my work has been made relatively simple by the previous speakers because each of them in their talk have covered some portion of this, and I'll keep it absolutely short and sweet. So to start with, trabeculectomy is a surgery which actually the drama begins post-operatively. On the table, however good a surgery you might perform, you have to actually be competent enough to handle the post-operative period, because it's a surgery which is against nature, where we pray. Every other surgery we pray for healing. Here we pray for non-healing because we limit the fibroblasts and want the ostium to remain open as long as possible. So trabeculectomy, as everybody else said, was started in 1968 and is the gold standard for glaucoma surgery. The limitations being wound healing at the episcleral and conjunctival planes. The early post-operative period, IOP is usually low for several days, but with increased outflow, decreased aqueous formation due to inflammation. In 2 to 4 weeks, IOP rises to the normal range. Increased outflow resistance due to scarring and aqueous formation returns to normal. So the three parameters here to be noted at every post-operative visit are intraocular pressure, depth of the anterior chamber, and height of the bleb. These are the three cardinal points. So high bleb and deep anterior chamber. So 9 to 15% the literature says incidence. With the rise in intraocular pressure, a few eyes develop high bleb and elevated intraocular pressure. Bleb cavity expands with aqueous but is limited by healing. Bleb wall balloons out. Encapsulated cystic cysts of 10-ounce capsule, high bleb, high intraocular pressure phase, firm tight appearing bleb with few or no microcysts. The risk factors being limbal based flaps, long-term use of topical beta blockers. So just to have a look at that colorful circle that we have here, the bleb wall is non-porous, causes poor fluid movement in the bleb. That leads to compression of the bleb wall, followed by compression of the vessels, and finally raised intraocular pressure transmitted to the bleb. So if you have a look at this, the encysted the encysted bleb that you see out there. So many of us have seen it in our practice over time, and the increased bleb height with absent microcysts that you see that in the UBM. So management of bleb encapsulation, IOP rises but eventually falls at 2 to 4 months in encapsulation. IOP reduction, well, aqueous suppressants can be used temporarily, and sustained IOP rise, bleb needling with antimetabolites can be done. You can do it at the slit lamp, or you can take your patient back to the theater and do it. And surgical bleb revision, I won't go into the details of that. We've had enough of conversation and discussion on that just before this. And partial or complete cyst excision, and of course you can go for a repeat trabeculectomy. So high bleb with shallow anterior chamber, that's usually due to pupillary block, aqueous misdirection, which we call malignant glaucoma, or suprachoroidal hemorrhage. Malignant glaucoma, posterior diversion and pooling of aqueous in the vitreous cavity, we all know that, triggered by sudden shallowing of the anterior chamber. Conjunctival leaks, overfiltration, you can actually by suture removal it can be caused, and sudden uniform shallowing of the anterior chamber. So anterior displacement of the iris root that you see out there again in the UBM, and the uniformly shallow AC that you see. I'm scared to touch this touchpad here because the slide is moving instead of the pointer. There you are, yeah. So that's it. So management of malignant glaucoma, medical, you have the aqueous suppressants and the cycloplegic lasers, well, aphakic, pseudophakic eyes, anterior hilar disruption with the YAG laser, and ciliary process shrinkage by the argon laser or the diode laser nowadays. So surgical, pars plana vitrectomy with disruption of the anterior hilate phase, frequent follow-up as relapse can occur, and long-term cycloplegias sometimes are required, and caution is the other eye surgery, to remember that. So suprachoroidal hemorrhage, clinical features, sudden onset of pain and nausea with diminution of vision, shallowing of the anterior chamber, loss of red reflex, and choroidal elevation. In the ultrasound, you'd see blood in the suprachoroidal space, and the treatment would be topical and systemic steroids, and larger hemorrhages would definitely require drainage by sclerotomy. So that's the suprachoroidal hemorrhage that you see in the UBM. So high IOP with low bleb, subconjunctival fibrosis at the conjunctival or the episcleral interface, and a patent sclerostomy. Management would be intraoperative antifibrotic agents like 5-FU or MMC. Then early postoperative period, postoperative steroids, digital massage, suture lysis. Digital massage, let me tell you, either you need to teach your patient or at least show the patient how to do it. Late postoperative period, check for patency of the sclerostomy, bleb revision, needling, failed bleb, or again a repeat trabeculectomy. So the take-home message would be here: intraocular pressure, bleb morphology, and anterior chamber depth, most important parameters to assess in the post-trabeculectomy eye. High bleb, treat according to the cause. Low bleb, that's definitely a failing bleb, and imaging to be used judiciously in guiding your treatment. These are my references, and thank you very much for your attention.
Questions? Chandrima, can you little elaborate on your way of doing needling?
Yeah, so initially I used to do needling at the slit lamp, and I was very confident. Let me tell you that in one of the best institutes like Moorfield, they always do it at the slit lamp. So they do it very confidently at the slit lamp. You definitely need a gonioscope, and you have to be confident in your gonioscopy. And after you perform the needling, generally we used to use 5-FU, but 5-FU nowadays is restricted use. So if you are confident enough to use mitomycin, as I think Dipanjan had said, the injection of mitomycin, but again, as Shagurikadi said, injection of mitomycin has to be with real caution, because you'd have the IOP drop like the mercury drops in a blood pressure instrument when you release the cuff. So basically nowadays what I do safer is to take the patient to the theatre, explain to the patient that, because if you do it at the slit lamp, you're safe, you don't have to tell the patient much, and you can do it even without the patient knowing about it. But if you take the patient to the theatre once again, you'd have to give reasons why you're taking the patient back to the theatre. But I think it's better to explain to the patient, be on the same page as the patient, and tell the patient what actually has happened, and take the patient back to the theatre, and then do the needling in a supine position, because that I think helps in every other way.